everyone for their attendance. Today it's my pleasure to be here with a friend and colleague, Ben Steinberg, and we're going to discuss some of the research that we've done in the past 2 years, specifically looking at clinical questions with the use of novel oral anticoagulant therapy. These questions came up while we were clinical fellows and upon the introduction of these new agents to practice. And as you'll see during our presentation, we identified the questions and then pursued them in slightly different ways. But I think you'll find that those ways are complementary to each other. So just a few conflicts of interest to disclose for both of us. So during my time at the DCRI, part of my research was invested in looking at the Rocket AF trial and answering several clinical questions using that data. Ben chose to focus on looking at the Orbit AF registry and answering questions in that observational way. Much of the data that we present today has already been published. However, some of it is still going through the gauntlet of peer review. As many of you know, that gauntlet can be long and torturous, so please watch out for that. As background, there have been 4 mega efficacy trials that have looked at the ability of novel oral anticoagulants to prevent stroke in non-valvular atrial fibrillation patients. And as of now, 3 new drugs have been approved as alternatives to warfarin for the prevention of stroke in non-valvular atrial fibrillation patients. However, as Ben will show in just a little bit of time, those agents are being slowly adopted by the clinical community. The evidence thus far would indicate that these new agents are at least non-inferior to warfarin for the prevention of stroke and in some cases superior. But bleeding rates and other complication rates are variable between trials and between when you look at individual different types of complications and bleeding. Thus, the following questions came up, and that was, what's the actual bleeding risk, and specifically for me, what's the GI bleeding risk associated with novel oral anticoagulants? How do we manage these new agents in patients who are on concomitant antiplatelet therapy? And finally, what's the optimal peri-procedural management of these new agents, especially around surgical or invasive procedures? Thus, during our presentation, our objectives will be to first describe the patterns of novel oral anticoagulant adoption, then to describe bleeding risk and specifically GI bleeding risk, as well as the ways physicians can use risk stratification both for thrombotic events and bleeding risk to choose the appropriate anticoagulation therapy, to describe patterns and outcomes associated with concomitant antiplatelet therapy use and novel oral anticoagulants in different clinical settings, and finally, to describe the patterns and subsequent outcomes of temporary interruption of oral anticoagulation in the current era. Ben's going to be first up, and he's going to discuss the community uptake of dabigatran in the Orbit AF registry.
Thanks, Matt, and again, thanks for everybody to join us. It's really a pleasure to present some work that we've done in the last couple of years, and I hope you all find it informative. As Matt noted, a lot of my time in the past 2 years was spent on the Orbit AF registry, which is a national outpatient registry headed up by Eric Peterson and John Piccini with funding from Janssen to look at outpatients with atrial fibrillation, predominantly managed by anticoagulation with 2 to 3 years of follow-up for clinical events. Again, it's an observational study. The first patient was entered around June 2010, and I show this slide because for the purposes of our analyses, the majority of patients was on warfarin, and dabigatran came about partway through the enrollment of the trial. By the time rivaroxaban and apixaban became approved, the registry was in follow-up, but we do have exposure of patients to warfarin and dabigatran, and I'll talk at the end of the study about the additional drugs. But essentially, Orbit is an observational registry of outpatients with atrial fibrillation in the U.S. and enrolled approximately 10,000 patients. So one of the analyses we looked at was the uptake of dabigatran in this community population. Again, these are cardiologists predominantly, but includes some electrophysiologists, some internal medicine providers or primary care providers, and it includes a very small proportion of neurologists as well. This is kind of chronologic uptake. We have dabigatran use at baseline, in other words, baseline in the registry as patients were enrolled. We have dabigatran in the purple in patients that were switched from warfarin to dabigatran, and then we have patients that were not on an oral anticoagulant at baseline, but then subsequently started dabigatran during the course of the registry. And so as you can see, there was some increase in uptake when it was first released up through the end of 2011, and then seemed to tend to level off even among the patients that were switching. Obviously enrollment leveled off, but the amount of switching seemed to level off as well, and it's also coincident with the approval of the two additional factor Xa inhibitors. Next, we were very intrigued. As many of you know, there was controversy surrounding the approval of dosing for dabigatran by the FDA until we were very interested in how providers are using this vis-a-vis renal-based dosing. As you know, the 75 milligram dose was not tested in the RELY trial, but as per standard FDA prior approval practices, this dosing was approved based on pharmacokinetic studies. And so we looked in ORBIT to see how patients were dosed, and overall the vast majority received the 150 milligram dosing. However, there was a significant minority of patients at the far side with greater age that were dosed at 75 milligrams. There was a significant minority of approximately 10% with preserved renal function that were dosed at the lower dosing, and then there was a relatively high proportion of patients with reduced renal function who still got the higher dose. And so I think, you know, we drew from this that the dosing is a challenge. People, I think, didn't, at the time this was run, and probably still don't totally appreciate how to dose these agents, and it likely affects outcomes. What we also were interested in is kind of how do providers decide to switch somebody to dabigatran in our population. And so these are results of a model we looked at to try to figure out which patients were switched from warfarin to dabigatran after adjustment. And I won't go through all of the details here, but essentially, as you'll notice at the bottom, there are factors associated with education, age, race that play into the population of patients that switched from warfarin to dabigatran. In contrast, these results demonstrate the factors that were associated with patients that were adopting dabigatran de novo. They were not on any anticoagulant to begin with, and what we took for this is there are more factors related to their disease process, what rhythm they're in, their heart rate, their current use of antiarrhythmic drugs, potentially different drivers of switching to dabigatran versus the patient that's on warfarin previously and moving to dabigatran. And so overall, you know, any new therapy is a challenge, no matter how exciting it is a challenge to implement. And I think we saw some skepticism or some hesitancy to adopt dabigatran early on, and also conflicts in terms of dosing. One of the concerns, not just with dabigatran, but with many of the agents, is a potential signal of GI bleeding in the trials. Overall bleeding generally was lower, but GI bleeding was a particular endpoint of interest in several of the trials, and so Matt's going to talk about that.
Thank you very much, Ben. As he mentioned, the comparisons of safety and efficacy between the novel oral anticoagulants and warfarin are extremely important for clinical practice. As you can see here, this is an illustration of that. This is a meta-analysis published from Christian Ruff and colleagues at TIMI, basically looking at pooled data from the 4 large megatrials. We can see that basically the novel oral anticoagulants are non-inferior, if not superior, in terms of prevention of stroke, but are indeed superior when it comes to hemorrhagic stroke and the incidence of intracranial hemorrhage. One of the concerns, though, is that when the data is pooled, there seems to be an increased risk for gastrointestinal hemorrhage with the novel agents. We decided to study this specific type of bleeding in the ROCKET-AF trial. So just as a review, the ROCKET-AF trial was a large randomized controlled trial of 14,000 patients. It was double-blind, double-dummy, designed as non-inferiority. It was internationally run. And it compared once-daily rivaroxaban to dose-adjusted warfarin for the prevention of stroke in non-valvular atrial fibrillation patients. The median follow-up in the trial was approximately 2 years, and as with all other clinical endpoints, GI bleeding events were adjudicated by a blinded multi-specialty adjudication committee. GI bleeding risk, or the time at risk, defined specifically for our study, was from the date of first study dose to 2 days after the date of last study drug dose. And seen here is a Kaplan-Meier curve of time to first major GI bleeding event in the safety on treatment group in the Rocket AF trial. As you can see, rivaroxaban treated patients had a significantly higher risk for major GI bleeding events as compared with warfarin treated patients. This is also shown by the hazard ratio at 1.42. When you then separate GI bleeding events into major or non-major clinically relevant bleeds, or separated them into the components of major bleeding, hemoglobin drop greater than 2 grams per deciliter or requiring transfusion, we can see that for each of these different types of GI bleeding, rivaroxaban treated patients had higher event rates, significantly higher event rates than warfarin treated patients. When we use multivariable logistic regression to produce adjusted hazard ratios, again, for each of those individual components of bleeding, rivaroxaban was associated with a higher hazard for GI bleeding. However, when you look specifically at the most severe forms of GI bleeding, that is those that are life-threatening and require transfusion of greater than or equal to 4 units of packed red blood cells, or those that result in death within 30 days of the incidence of GI bleeding, you can see first that the number of bleeds that occur that are this severe is very low, and second, that it seems to be balanced across treatment arms. That is, rivaroxaban and warfarin-treated patients seem to have similar risk for these events. When we then use multivariable analyses to look at independent factors associated with GI bleed, I list here the 5 most significantly associated. That is anemia at baseline, a history of prior GI bleeding, concomitant aspirin use, rivaroxaban use, and increasing age. These factors may help us to determine which patients we should consider for risk stratification as higher bleeding risk and thus maybe alter our anticoagulation therapy. Again, there's not a lot of data to use in order to assess both bleeding and thrombotic risk and then make that very, very difficult decision. Finally, the conclusions of our trial are that rivaroxaban is in fact associated with an increased risk for both major and non-major clinically relevant GI bleeding. However, that association is not with rivaroxaban alone. It's actually seen in dabigatran with the RELY trial. It's seen with edoxaban in the ENGAGE trial as well. And we'll come back to apixaban in just a moment. The mechanism by which these novel oral anticoagulants exert this increased GI bleeding effect is not well understood. All of these agents are actually substrate to the P-glycoprotein transport system, and it's postulated that that system may increase both the time and the concentration of active study drug that remains in the gut. They are active, and so they could act on surface lesions in the gut to increase bleeding. And as a reminder, warfarin is almost completely bioavailable, and thus it's almost immediately absorbed and is not an active agent in the gut. And so that's one mechanism by which these agents could have increased GI bleeding. That does not explain the difference that we see here with apixaban versus the rest of the agents. It's possible that apixaban could be different biologically or pharmacologically, but it's also possible that the major bleeding events that are seen in the Aristotle trial used a slightly different definition than the major bleeding events in all the other trials. And so it might be just an artifact of a different definition. But one of the major conclusions from our trial is that it's very, very important with each individual patient to use methods to stratify their risk, both for thrombosis and bleeding, so that we can choose the optimal anticoagulation strategy. And Ben is going to talk more about data from the ORBIT AF study on that assessment of risk.
So, as Matt mentioned, one of the most important aspects of anticoagulating patients in atrial fibrillation is their assessment of risk. Again, both of stroke and bleeding risk. Many of us are very familiar with the stroke risk scores, but not necessarily how well they're used. One really unique design aspect of the ORBIT registry, and this is attributed to the input of John and Eric in the design of putting this in the CRF, is essentially for every patient in ORBIT, we had the investigator or the physician subjectively tell us what they thought the patient's stroke and bleeding risk were. They could use whatever they wanted to do that. They could calculate a CHADS-2 score, they could look at everything, they could talk to the patient, they could review the record. However they wanted to gauge that, we just asked them, what do you think it is, low, medium, or high? And we specified event rates with those risk levels to help them calibrate that. And unbeknownst to them, those were based on event rates in the derivation populations of the major risk scores, those being the CHADS-2 score at the time this was developed, and we chose to use the atria bleeding score. As you know, there are several. And so the first question was, among the 10,000 patients in orbit, how did providers do? How did their assessment agree with that of the empiric or the objective scores? And so on the columns here, we have the different CHADS score levels, 0, 1, and 2 or more. Again, these cutoffs were chosen based on the event rates in the derivation population in the original JAMA publication. These are column percentages, and so on the rows we have what proportion of those did the investigator attribute to that stroke's level. And so among the 644 patients with a CHADS score of 0, who we would categorize as low risk, the investigators categorized 78% of those patients at low risk. Not bad, obviously not everybody, but not bad. As you can see across, moving down the diagonal in the CHADS-1 cohort, there were approximately 2,200 patients in our cohort that had a CHADS score of 1, and we classified those as intermediate by CHADS score, and the investigator only categorized a third of those patients at intermediate risk, and even more concerning, they categorized 62% at low risk, so they underestimated those patients' risk. And I think as we all acknowledge the limitations of the CHADS score at the low end of risk, these patients actually by CHADS-VAS could have been quite high risk. Lastly, you'll see on the last column that providers identified only 20% of those patients at the highest CHADS-2 risk score. Similarly, so this is the similarly designed figure for bleeding risk according to atria levels. Again, the atria score cutoffs were based on event rates in the original derivation cohorts. Approximately 2/3 of low atria risk patients were identified as low risk by the provider. Approximately 1/3 of intermediate risk, and approximately 10% that were high risk by atria for bleeding, the providers identified as high risk. So very low correlation, and that was evidenced in our statistical analysis as well. We looked further at use of anticoagulation in these patients. In other words, the providers made their risk assessment, we calculated the score. How were these patients actually treated? And so if we look at the treatment rates by stroke risk, in the back is the physician risk, and in the front is the CHADS-2 score by low, medium, high, and on the Y is the rate of treatment. So in the yellow, as you go from left to right, there's slightly increasing rates of anticoagulation use by physician assessment of stroke risk. Similarly, in the front, there's perhaps even more dramatic change from approximately half of CHADS-0 patients being anticoagulated to approximately 80%. It appears that physicians, whether through their own assessment or CHADS score, or they're one and the same, physicians do at least appear to take into account stroke risk when they prescribe oral anticoagulation, and of course that's consistent with the guidelines that recommend we do so. In contrast, if we look at use of anticoagulation by bleeding risk, whether we look at the physician's assessment of the bleeding risk or the atria risk scores, and it should be noted, of course, that unlike CHADS, bleeding risk score, particularly at the time this was done, was not part of the guidelines. Nevertheless, the guidelines have included, the caveat that you should always consider the patient's risk of bleeding in the use of anticoagulation, naturally. But as you can see, there's really not a clear trend towards decreasing use of anticoagulation as bleeding risk increases. I think we stop short of saying, is this right or not, because I think it's well known that we lack the data to really tell us that withholding anticoagulation in some group of patients provides them net clinical benefit. But clearly, the providers don't appear to use bleeding risk in their use of anticoagulation And I think we still struggle with how to use bleeding scores in the routine management of patients, in contrast, of course, to research use of bleeding scores. And so if you don't know how to use that, you might not see any problems. I'll move on and change gears a little bit to kind of how we might use this. In other words, there clearly are patients at risk of bleeding. Matt alluded to this a little earlier in the ROCKET data, in specific the use of antiplatelet therapies in patients that are also on anticoagulation. And this is currently a great interest. This has been a great interest of ours in terms of the risks and benefits of concurrent antiplatelet therapy, if it's just a baby aspirin or if it's highly potent modern antiplatelet therapy. And so in ORBIT, we also looked at the use of concomitant aspirin therapy in patients with atrial fibrillation that were anticoagulated. So we stratified the ORBIT population by those that were receiving anticoagulation alone. The vast majority, I should say, were receiving warfarin, if not actually all in this population. And then those that were receiving warfarin plus aspirin. This didn't include any dual antiplatelet therapy or other antiplatelet agents. This was only anticoagulation versus anticoagulation plus aspirin. As you can see, there are significant demographic differences between the patients that were just receiving anticoagulation versus those with concomitant aspirin therapy, but bleeding risk scores didn't appear to be different. Not surprisingly, risk factors for cardiovascular disease were higher in those on aspirin. Stroke risk scores were slightly higher as well in those receiving aspirin, but one of the major findings we thought was highly intriguing was the fact that if we look at kind of what we think of as major indications for antiplatelet therapy, at least even independent of anticoagulation, we usually think of manifest cardiovascular disease, those with coronary, peripheral, or cerebrovascular disease. And so among our population, approximately 37% of those patients that were on anticoagulation alone had cardiovascular disease, and so those patients weren't receiving a concomitant aspirin therapy. The utility of that could be debated, of course. Nevertheless, only 60% of patients receiving oral anticoagulation and aspirin had cardiovascular disease. So if we flip that, we could say that 40% of patients that were receiving aspirin with their anticoagulation had no manifest cardiovascular disease. Perhaps they had diabetes, perhaps they had risk factors, but certainly they didn't have the highest indication for aspirin therapy. And so, of course, the next question is, well, does it matter? And so we looked at outcomes in these patients. These are unadjusted rates of major bleeding by ISTH criteria. As you know, there's a rather significant bleed. And among every subgroup, whether you look at age, prior GI bleeding, or atria score, risk of bleeding was increased in those on aspirin with their anticoagulation in the purple versus the blue anticoagulation alone. Nevertheless, of course, these are unadjusted data and don't necessarily account for baseline differences. So after adjustment, we see on the top bar risk of major bleeding associated with the concomitant use of aspirin in addition to the anticoagulation therapy, a hazard of 1.5, nearly 50% increase in risk of major bleeding for patients that are treated with aspirin in addition to the anticoagulation. This is all comers. Consistent with that, we saw an increase in bleeding hospitalization as well, significantly increased. We hope to look at ischemic outcomes. Right? One of the questions would be, well, are they benefiting from their aspirin and preventing cardiovascular events? As many of you are aware, patients that are on oral anticoagulation, systemic anticoagulation, actually have extraordinarily low rates of ischemic events, and that often limits many of the analyses, both in ROCKET and ORBIT and many other studies of anticoagulation, and that the event rates are quite low for those types of events. But nevertheless, this data suggested, and I think for me, highlighted that aspirin really, I don't believe, is a benign therapy, particularly in the patient that is on systemic anticoagulation. Nevertheless, these data were largely limited to warfarin-treated patients. And so Matt's going to talk a little bit about similar types of data in the novel oral anticoagulant group.
Thank you, Ben. So we also wanted to study concomitant antiplatelet therapy with specifically novel oral anticoagulants. But we elected to study rivaroxaban in the ROCKET-AF trial in a very specific clinical situation, and that was in patients that underwent PCI. We also thought this would be common in a moderate to high-risk group of patients who were enrolled in this trial. So to our surprise, we found that in the 14,000 patients in the ROCKET-AF trial, the rate of undergoing PCI was very low, at less than 1% per year. There were only 92 patients in the warfarin-treated group and only 61 patients in the rivaroxaban-treated group that underwent PCI during study follow-up. There was a significant difference. That was, warfarin-treated patients were at significantly higher risk for PCI than were rivaroxaban-treated patients, as is also shown by a shorter median time to first PCI for warfarin-treated patients. We also looked at how antiplatelet therapy was used at 30 days post-PCI in this study population. I should note that the study protocol for ROCKET indicated that patients could indeed continue study drug during and after PCI, and that the type and duration of antiplatelet therapy was left to the investigator's discretion in the trial. Thus, as you see on the bottom of the slide, 81% of patients who underwent PCI remained on study drug post-PCI for at least 30 days. 40% of those patients also received dual antiplatelet therapy with aspirin and clopidogrel. 34% of patients received monotherapy with either aspirin or clopidogrel, and a smaller percentage, 15%, received no antiplatelet therapy in addition to study drug, while 12% switched from dual antiplatelet therapy to monotherapy at 30 days. How does this relate to clinical outcomes? Well, we first compared the clinical outcomes of patients who underwent PCI with those patients that did not undergo PCI. And as you can see, shown here in events per 100 patient years, patients undergoing PCI were at significantly higher risk for stroke, systemic embolism, myocardial infarction, vascular death, and major or non-major clinically relevant bleeding. This is not surprising. Many of these patients who underwent PCI did so for acute coronary syndrome and were thus at high thrombotic risk. And as I just showed you, many of them were also on concomitant antiplatelet therapies that would increase their bleeding risk. When we then switched to comparing this very small group of PCI patients, stratifying them by treatment arm and then comparing their outcomes, I would first note that it was a much smaller group than we had initially anticipated, and thus there are very few events to compare. But what we can say using this data is that event rates, both thrombotic and bleeding event rates, are fairly high in patients post-PCI who receive warfarin or rivaroxaban and in addition concomitant antiplatelet therapy. Finally, when we looked at event frequency plotted in the time interval seen on the bottom of the slide, there was a clear clustering of thrombotic and bleeding events post-PCI. Stroke, systemic embolism, myocardial infarction, and major bleeding all seemed to occur within the first 6 months post-PCI and tapered significantly thereafter. Vascular death was the only exception to this, where events seemed to slowly accrue over the study follow-up period. So in conclusion, for these results, we thought first that the risk for PCI in this moderate to high-risk group of atrial fibrillation patients was fairly low at less than 1% per year, and that's likely because they were on effective oral anticoagulation. However, their risk for bleeding, because many of them were taking concomitant antiplatelet therapy, the risk for both thrombosis and bleeding was very high, and that should serve as a warning when we're thinking about combining antiplatelet therapy with novel oral anticoagulants or warfarin. Finally, in comparing rivaroxaban to warfarin, these data really can't speak to that comparison because we just don't have enough patients and enough events to reliably make that comparison. However, the clinical question is extremely important, both to practicing physicians as well as to industry. And so 2 trials have already been announced that are going to study novel oral anticoagulants in this particular setting in patients undergoing PCI and who are going to need concomitant antiplatelet therapy. The first is the Pioneer AF PCI trial looking at rivaroxaban, and the second is the Redual PCI trial looking at dabigatran. There are rumors that the other 2 companies are also soon to announce similar trials looking at the use of novel oral anticoagulants in the PCI population. Switching gears a little bit, I'd also like to speak about an important clinical question that comes up with all oral anticoagulants. It's commonly encountered and happens very frequently, and that is the interruption of oral anticoagulation for a variety of clinical reasons, including surgical or invasive procedures or others. There are very few data available on both the incidence and the prevalence of temporary interruption, as well as the associated outcomes, certainly in the current era of oral anticoagulation, and thus we decided to study this in the ROCKET-AF trial. First, this topic is not as familiar to most people as the others we've discussed, so let me first go through the methods very briefly. Temporary interruption for this study was defined as cessation of study drug for greater than or equal to 3 days, ending with the eventual resumption of study drug. The at-risk period that we defined for events that might occur during temporary interruption was the start of interruption, the day of interruption, until 30 days after resumption of study drug, in an effort to capture those events that would be related to the interruption. Median follow-up for the trial, again, was 2 years, and the median duration of temporary interruption during our trial was about 5 days. We looked at both efficacy and safety outcomes for our temporary interruption study. So the first major finding was that temporary interruption is incredibly common in the ROCKET-AF trial. A third of patients, over 4,600 patients, experienced at least one interruption of their study drug. And that led to over 7,500 temporary interruption events in general. When you then look at what caused that temporary interruption, 40% of them were for surgical or invasive procedures, which we've seen in previous literature. 25% were for adverse events that were not related to bleeding, while around 13% were related to adverse events that were related to bleeding. Perhaps unique to clinical trials, but likely not unique in the community, is that 20% of temporary interruption was due to subject error, and around 6% for logistic difficulties. For those 40% that were due to surgical or invasive procedures, the most common procedures requiring temporary interruption were colonoscopy or GI endoscopy, as well as dental work. Less commonly was abdominal or thoracic or orthopedic surgery or dermatologic procedures, and invasive cardiac procedures such as EP ablations, device placements, angiography, PCI contributed to a lesser degree. A limitation of our data is that for 10% of these interruptions, we didn't know exactly what surgical procedure occurred. Finally, when we look at the clinical outcomes associated with temporary interruption, again, that occurred during the at-risk period that I described before, first we can see that despite the very large number of patients and temporary interruptions that we had in the trial, the absolute number of events that occurred in this very short risk window was small. However, when you calculate the event rate per 30 days, these are very high event rates per 30 days for both stroke, systemic embolism, death, myocardial infarction, and any type of bleeding. Despite this high risk of these events, that high risk is fairly similar across rivaroxaban and warfarin-treated patients. We then looked at patterns of bridging anticoagulation, and let me mention that during the ROCKET-AF trial, investigators were encouraged to use bridging therapy if patients were deemed high risk for thrombosis, and that was defined as having more than 2 CHADS risk factors. However, this was not mandated. It was left to the investigator's discretion whether to pursue bridging therapy and what type of bridging therapy to use. So we were surprised in this pretty high-risk group of patients that bridging was only used in less than 7% of patients who had temporary interruption. When bridging was pursued, over 98% of patients received low molecular weight heparin, and the duration of bridging was commensurate with the duration of temporary interruption. When we then look at clinical characteristics of patients who received bridging versus those that did not surprisingly, there were small differences. Patients receiving bridging therapy were slightly older, less likely to be female, had higher CHADS to mean risk scores, and were less likely to receive chronic aspirin, but more likely to have been on vitamin K antagonists prior to the trial. Then when we compare outcomes for patients who received bridging therapy versus those that did not, we were very cautious here. Now this is, the bridging therapy group is a subgroup of yet another subgroup, and so there are very, very few patients and events to look at. What we can say, though, is that the thrombotic and bleeding event rates were still high, whether you received bridging therapy or whether you didn't receive bridging therapy. And there might have been a hint that bridging therapy was associated with slightly more bleeding. So in conclusion, for this study, we thought that first, temporary interruption of oral anticoagulation is incredibly common, and all of us are likely to see it many times in clinical practice. We also would conclude that temporary interruption is associated with very high risk for both thrombotic events and bleeding events, and thus clinicians should try to minimize this if at all possible, even around surgical or invasive procedures. Finally, in comparing bridging versus not bridging, I think the jury is still out. We don't have enough data to make any strong conclusions about whether bridging is effective in either preventing thrombotic events, and again, it may be associated with some increased bleeding around surgical or invasive procedures. With that, I'd like to give it to Ben. I think an even better population to study this in would be perhaps a real-world population, and Ben is going to talk about the Orbit AF registry.
So again, Matt gave a nice description of interruptions of anticoagulation in the trial. And as we know, there are advantages and disadvantages to each of the methodologies. Naturally, we looked at interruptions in a quote-unquote real-world community cohort of patients with atrial fibrillation, again, the majority of which were treated with warfarin. Similarly to the trial, we noted a very common incidence of temporary interruptions for procedures in Orbit AF. I'll underline that we, in Orbit, only looked at interruptions for procedures. So we didn't even look at interruptions that were due to incident bleeding or mistakes or confusion or any other reason other than procedures. And even just procedures, within 2 years, there are almost 3,000 interruptions of oral anticoagulation. In this community cohort, about a quarter of all interruptions involve the use of a bridging anticoagulant, the vast majority including a low molecular weight heparin, followed by much less commonly unfractionated heparin. But we felt a significant proportion of these interruptions. We did note that that there were 23 bridged interruptions that involved dabigatran. Those patients that were on dabigatran that subsequently were bridged with another anticoagulant that, at least I would argue, probably has the same pharmacokinetics as dabigatran. We then compared the patient characteristics between patients that had an interruption, but none of them was with bleeding, so they had at least one interruption of their anticoagulation, but none of them involved a bridging agent. That's on the left, and in purple on the right is patients with at least one temporary interruption that had bridging. They could have had multiple interruptions, but at least one of them involved a bridging agent. Naturally, there were some differences in age. The CHAD scores were slightly higher for those that were bridged. There were some particular characteristics that consistent with at least the recommendations, in other words, prior cerebrovascular events, the presence of a mechanical valve, significant difference in terms of bridging. Notably, no difference between in prior GI bleeding rates, albeit low, and as we would expect, differences in the use of baseline anticoagulant. Obviously, those on warfarin more likely to be bridged than those on dabigatran, but nevertheless, there were some patients on dabigatran that had bridging, somewhat to our surprise. In contrast to the chart Matt showed, this graph illustrates the rates of bridging by interruption for different procedures. So on the X are the different procedures that required an interruption, and on the Y is the rate of bridging for that procedure. As you can see on the left, dental procedures very unlikely to be bridged. However, we had 240 interruptions for dental procedures. Some would argue maybe you don't even need to interrupt for that, but there were patients that were had interruptions and were subsequently bridged. On the right side, we saw procedures such as cardiac surgery, catheter ablation, cardiac catheterization, with the highest rates of bridging for those interruptions. Subsequently, we looked at outcomes following interruption stratified by the use of bridging. And so this is on an interruption level, interruptions that did not have bridging versus interruptions that did. Again, thromboembolic events, ischemic events, relatively low, but across the spectrum in unadjusted fashion. I should say this, excuse me, this is at 30 days. Rates of adverse events, including major bleeding, cardiovascular and bleeding hospitalizations, as well as other hospitalizations, higher in the bridging cohort, and relatively high, a 5% rate of being rehospitalized within 30 days. Of course, these are unadjusted data, and so obviously we need to adjust for baseline characteristics. And when we do that, we see that using a composite for cardiovascular bleeding and overall composite, so the cardiovascular events including stroke, systemic embolism, MI, or cardiovascular hospitalization, numerically higher in patients that underwent bridging. This includes adjustment for the type of procedure that they underwent, the type of anticoagulant they were on, but numerically higher for those that were bridged but not significant. In contrast, for bleeding events, substantially higher, 1.3 versus 5. 5 events, and then adjusted odds ratio of almost 4 in terms of risk of bleeding events within 30 days following interruption if you underwent bridging. And then the overall composite of really just anything bad happening to you within 30 days, significantly higher following interruptions that were bridged. Now, obviously, with the observational nature of this design, we cannot definitively assign the cause of this risk to the bridging, but I think it deserves further study. The guidelines around this topic are supported by limited evidence. As many of us know, Duke is heavily involved in the bridge trial, looking at this at least in one fashion, and we think these are concerning data nevertheless. And so that sort of rounds out kind of an overview, a bird's eye view of a lot of what Matt and I have worked on the last couple of years. We wanted to highlight a few kind of where we see future directions for each of our respective interests and field. And so I'm excited to be involved already within the last 6 to 12 months of the next phase of the Orbit program. Again, this is entirely thanks to the leadership of John Cheney, Eric Peterson, of embarking on the next phase of Orbit, which is Orbit 2, is another 15,000 patients, outpatients with atrial fibrillation. Notably, the objectives here are to look at those novel anticoagulants. And I think importantly and most intriguingly for many of us is the objective of A, looking at all of the anticoagulation strategies, and B, focusing on those patients that are transitioned to novel anticoagulants. Most importantly, we're going to look at major procedures and the management around procedures and bleeding. In other words, there's separate CRFs and specific interest in how these agents are managed around procedures, how patients are bridged, what their outcomes are for certain procedures, and I think even most importantly, how patients are managed in the setting of bleeding with these agents, how they're treated and how they do, whether the bleeding is related to a procedure or not. And so I'm very excited to be involved with the next phase. Just to give you an idea, we've already enrolled over 3,000 patients. These are preliminary data actually from several weeks ago. But essentially, we're trying to balance enrollment across the anticoagulant strategies. You can get in if you have new AF but are not anticoagulated, and so we hope to have a robust comparator within the population, and obviously will include any agents subsequently approved during the time course of the study. One of the most fascinating aspects of preliminary data so far, I think, are the rates at which patients are transitioning between and among these agents. So even within 6 months of follow-up, again, this is a small proportion of patients, but among the different anticoagulant strategies on the x-axis here, the y is just the percentage of those patients that were treated at baseline with one strategy and switched to something else by 6 months. And so those, about 10% that were on nothing at baseline started something, and as high as almost a third of patients on dabigatran at baseline changed to something else, whether they stopped it or changed to something new. And I think, at least my personal opinion is, particularly with these drugs, that transitions probably are not great unless there's a very specific reason. And so I think this is very appetizing in terms of the data, the analyses, the conclusions we can draw, and the further questions we can ask. And so stay tuned in the future for these data.
I'd like to split my closing kind of future directions into two different parts. The first is the directions of research that I'm going to pursue based on kind of the data we presented today. We'd like to look at the use of novel oral anticoagulant agents in patients with significant valvular disease, and that includes patients who have bioprosthetic valves. And Sean Picorni, John Alexander, and John Vivalli and I are looking right now at that population in the Aristotle trial. I'd also like to look at new and emerging technology that's coming down the pike that is a different way to mitigate stroke risk for patients with atrial fibrillation, and that is left atrial appendage closure. There is a device already approved, the Lariat device, and I think soon to be approved is the Watchman device. So I'd like to study, and with the help of Ben and John Piccini, study how practice patterns of left atrial appendage closure work out, as well as long-term outcomes with left atrial appendage closure devices, both for safety and for efficacy in terms of stroke prevention. But I think the data that we present today offer a unique clinical opportunity. Some data not shown, but that's particularly relevant, are that most of the novel oral anticoagulant prescribing is being done by cardiologists. Primary care doctors are very hesitant to start novel oral anticoagulants in patients, be it from a lack of experience or perhaps not as wide a dissemination of knowledge about these agents. And that's concerning because there are several upsides to the agents themselves. I believe at Duke and at other large academic centers that we should initiate a thrombotic risk and bleeding risk clinic that would bring together general cardiologists, electrophysiologists, structural heart specialists, and hematologists, so that we might provide expertise and perhaps advice about patients' oral anticoagulation strategy, and in the future, I believe, hopefully pick appropriate candidates to undergo left atrial appendage closure if that would in fact be the best strategy for them. Now I'd like to switch gears though and talk about something that I'm passionate about, and that is registry-based research in structural heart disease. We have a very unique opportunity here at Duke. The STS-ACC TVT registry is actually a collaboration between professional societies, the STS and the ACC, the FDA, CMS, and DCRI. And the goal of the TVT registry is not only to do post-market surveillance of these devices and to provide a reasonable introduction of new devices to the clinical setting, but also it allows a data infrastructure to look at appropriateness of TAVR procedures and also perhaps embed novel studies such as have been pursued so far, new IDEs in valve-in-valve procedures as well as for alternative access sites for TAVR. So I'm very excited to be involved. For the last 9 or so months, I've been working under the guidance of Eric Peterson, Adrian Hernandez, and Matt Brennan on the operations committee of this registry at the DCRI. So the TVT registry was launched in 2012, and as published in JACC in late 2013, there are already over 8,100 patients as of August 2013 in the registry. Because reimbursement through CMS is tied to involvement with the TVT registry, it has the potential to include nearly all of the patients who receive a commercial-based TAVR device in the future. And again, under appropriate guidance, I've been able to work with the data and submit proposals to evaluate this data specifically for the use of antiplatelet and anticoagulant agents peri-procedure and post-procedure for TAVR patients. I believe there will be significant variability in how patients are treated and that this variability will contribute to clinical events. In addition, we're currently working on proposals looking at in-depth risk factors for stroke, looking at access site versus non-access site bleeding in TAVR, and also a topic near and dear to my heart, looking at the use of transfusion in these patients who happen to be at very high risk for thrombosis and bleeding when they have their procedure. Of course, none of this could be done without guidance and mentoring from faculty members, both at the DCRI and here at Duke. We would like to take a moment to thank all of these very generous people. This is by no means a comprehensive list of the people that have helped us, but we wanted to acknowledge these faculty members in the development of our research and our careers. So with that, we'd be happy to take any questions from the audience. And we'd like to say thank you very much for your attention.